Thanks, Carol, and welcome everybody to this session. I must confess, after me, you'll have some wonderful speakers, so I have this role to begin. These are my disclosures. Okay, so before I start, I just wanted to make the point that this is Altiplace. Altiplace is a TPA, a tissue plasminogen activator. But this guy here is tenecteplase. It differs in 3 glycoprotein moieties in T, N, and K, 2 in the Kringle domain. But this is also a TPA. It is a tissue plasminogen activator. So Altiplace and tenecteplase are both TPAs. That's how it sort of begin the talk. But there are some differences, obviously. Tenecteplase, because of these 3 moiety differences, is a little bit more fibrin specific. Therefore, it has sort of slightly more resistant to pi1, and therefore potentially has more thrombolytic potency. But interestingly, it also potentially depletes less fibrinogen systemically, which could translate into slightly less bleeding risk. So before I sort of now go into my talk, I wanted to present this as some axioms. And so axiom 1, we all agree, I presume, that thrombolysis works. The 2 thrombolytics that we have, tissue plasminogen activators, Altiplace and TNK or tenecteplase, work. They work by activating plasmin, which then breaks down thrombus. There are some other mechanisms. I had this pleasure of listening to this incredible session in the morning at around 7. There are drugs that now potentially can inhibit alpha-2 antiplasmin. There are drugs that would act on nets, thus helping clot lysis. But today we'll discuss about thrombolysis with tissue plasminogen activators, or TPA. Now, we have a long history of thrombolysis. It is hard for us to imagine that we have known about thrombolysis for almost 100 years now. But it is in the last 25 years that thrombolysis in humans has succeeded in improving outcomes in patients with acute ischemic stroke. Of late, though, we have had trials now with tenecteplase. Many of these trials have shown that tenecteplase can be a replacement for Altiplace, the drug we've been using for almost 25 years. I just wanted to show you this slide with these 2 usual suspects, Altiplace and tenecteplase. This is the Emberson data. This is the most, the paper I sort of quote everywhere. This was a meta-analysis of all the Altiplace trials, and as you can see, it was from this paper that we come to know that time is brain. That the faster you treat with thrombolysis, the better the patient outcomes. And now, from my colleague, Dr. Singh, I'm not sure whether she's here, but this is from our own trial, ACT, where we see that the time effect of thrombolysis with tenecteplase is almost the same as Altiplace. So time is brain, both with Altiplace and with tenecteplase, with both TPAs. I just also wanted to show this slide. I know that most of you are not sort of thrombolysis skeptics, but we do have a community in North America who are sort of thrombolysis skeptics. So this is, a slide from Intersect, the observational study we did, and you can see recanalization rates over time. So this is on the y-axis probability of recanalization, and on the x-axis it's time from thrombolytic bolus. As you will see, when you do not give thrombolytics, there is actually a flat line. Clots do not open up in humans. Versus when you give thrombolytics, then clots do open up. So clots do open up with lytics for the skeptics in the crowd, right? I also wanted to stress on the global burden of stroke. We are the World Stroke Congress, or the World Stroke meeting here, and this is something that we can't lose sight of. This is from the Lancet Neurology in 2021 from the Global Burden of Disease study. And as you can see, the incidence of stroke world over, there is significant burden in Africa, in most of Asia, even in South America. And what is also interesting is this slide. You would see that the utilization of acute stroke treatment, and this is US data. This is with intravenous thrombolysis. The utilization rates, in fact, in rural and remote rural areas are quite low and have been plateauing, so it's not increased. There's a significant gap. Even these numbers, so if you look at utilization rates around 8 to 10%, I feel is a significant underestimate from what could actually be done with thrombolysis. Not to mention the point that even with endovascular treatment, the utilization rates are quite low. So there's a significant gap in the offering of hyperacute stroke treatment. And so I was wondering why this question, is there still a role for TPA in hyperacute ischemic stroke? There is a role for tissue plasminogen activator in hyperacute ischemic stroke. In fact, it is the only drug that seems to work in hyperacute ischemic stroke, so thrombolysis works. Faster thrombolysis results in better outcomes, and hyperacute stroke treatment with thrombolysis is significantly underutilized. Now that we accept this, I now wanted to nuance that question further. I presume, people are talking about tenecteplase as an alternative to Altiplace, which is called TPA. And so, as usual, with the Europeans, with the excellent review, so I sort of had to borrow from ESO 2022. This is a meta-analysis of all the trials done up until 2023. Carol, like the TRACE trial is still not there, but you would see some of these other meta-analyses that actually have included that trial too. But if you look at this outcome now is ranking 0-1, and you look at the forest plots. So the way I have been trained to interpret forest plots is I actually look at the point estimates. And where are these point estimates? So if you see this line here, most of the point estimates are actually lying in this direction, favoring TNK. So I have heard this, and I've been privy to multiple debates on this issue, where the idea that we do a non-inferiority trial is often considered as, you have shown non-inferiority, but that does not mean superiority. The point is that when you actually do a trial, you have to choose a certain outcome. When you do a non-inferiority trial, you would actually choose a certain outcome, but there are other outcomes and other reasons why this drug could actually be more convenient to use. But now if I look at this forest plot and look at all the point estimates, all of them seem to be in the direction of TNK, which overall, at least in my opinion, means that TNK is showing itself to be better for this outcome when compared to Altiplace. Now, this is intracerebral hemorrhage. Any intracerebral hemorrhage, which I find is actually a better marker of bleeding risk than just symptomatic ICHs, where there is a clinical aspect to the interpretation. And so if you actually look at symptomatic ICH rates and look at the forest plots here, all of them seem to be in this direction except for this particular study. And then if you look at the composite diamond plot, you would see that that is favoring tenecteplase. And now look at mortality, and again look at this line here, and look at where the diamond plot lies and where most of the point estimates lie. They are either similar or in the direction of tenecteplase. What does this overall mean? If I have the luxury of doing a 10,000 or a 20,000 patient study, as the cardiologists do, I might actually clearly show that tenecteplase is better than Altiplace for most of the outcomes. But because in stroke we are unable to do such large trials, our largest trials now are in the thousands or 2,000s. The ACT trial we did was 1,600. Keith would be presenting their test 2 trial tomorrow, which would be 1,800 patients. We build towards that sort of evidence. But the data seems quite convincing, at least for our core outcomes, that tenecteplase is a very good replacement for Altiplace. There's also this issue about cost now, and this is from a Dutch study published in the European Stroke Journal. So this is, the percentage cost effective, and the way to interpret this is sensitivity analysis. And so the willingness to pay, if it is say 10,000 euros for A-quali and you increase it to 30, 40, 50, 60, 70,000 euros for each quality-adjusted life year, you'll see across the scale, across the willingness to pay, tenecteplase seems to be more cost-effective. Now, you might say that this is conditional on the cost of tenecteplase itself, but there are other factors, including, less use of intravenous infusion pumps, less use of IV lines, faster treatments, less DDO times, less need for transport crews, that would all sort of, play into cost effectiveness. And so Axiom 4, tenecteplase is a better alternative to Altiplace. Both of them are TPAs in patients with acute ischemic stroke. Why? It could potentially result in better recanalization, potentially be safer than Altiplace. It has all these workflow benefits. It's a bolus injection, not to mention the fact that it improves the quality of life of us physicians as well as our nurses. So there's that aspect too, in addition to helping patients. And then there is cost savings. So then why this question? So there's also this debate going on about large vessel occlusions and thrombolysis with TPA, be it Altiplace or tenecteplase. This was a paper that Dr. Demchuk and I led. This was the INTERSECT study. This was that study that was looking at recanalization rates with thrombolysis in clots of different origins. And if you can see here with this figure here, this is internal carotid artery thrombus. You would see on the y-axis is successful recanalization, on the x-axis is time from giving the bolus of Altiplace to when you assess recanalization. You'll see that early on, within the first few, within say, like the first 1 or 2 hours, recanalization rates with ICA for Altiplace is very low. It does increase for M1 segment thrombus. The blue and the yellow are the type of clots, permeable and non-permeable clots. Permeable clots seem to recanalize more. But from this figure, you do understand that early on with thrombolysis, the recanalization rates in LVOs and especially with ICAs are quite low. This was what led to the idea of the bridging trial. So whether I should actually give thrombolysis to people who are going endovascular with large vessel occlusions, or should I not? And we had around 6 bridging trials over the last few years. They were all combined into this meta-analysis at a patient level called IRIS. And you see the Grotta bars. Now, I wouldn't comment right now on the statistical, whether it met its non-inferiority threshold. It did not. But if you look at the Grotta bars, which is what I do, or the Rankin distributions, you'd see that they seem almost similar. Although, if you look at certain outcomes, you would see that there is a 2 to 3% difference potentially in favor of when you give Altiplace. And if you go and look at mortality rates, or you, then, there's slightly less, 1% less. And unfortunately, even the combined meta-analysis did not actually succeed in showing non-inferiority. So for the statisticians, the comment would be, So there was no evidence of non-inferiority. So it's like a 2 double no's there. But I did a sort of theoretical experiment. So this is, I extrapolate the ACT data onto this slide. And so this is Altiplace and this is tenecteplase. So for the primary, for Rankin 0-1, you would see that tenecteplase seems to be better, although it sort of, seems to go slightly in the other direction for some of the other Rankin distributions. Overall, I think, it might actually show maybe some similarity. But if you extrapolate or, superimpose the extend IATNK data, which was a smaller study, but also, like only in large vessel occlusions, you'd see that tenecteplase seems to have, this differential effect over Altiplace in people with large vessel occlusions. And so if you think that tenecteplase has this incremental 2, 3, or 4% benefit, and Keith would tell us tomorrow, please attend that session. The ATTEST-2 trial is being presented tomorrow. If there is that incremental benefit over Altiplace, and then the bridging trials seem to suggest that there is an incremental 2 to 3% benefit of bridging, then overall, if you add up these two things, which is not what you're supposed to do, but I'm saying, if you add up these two things, then maybe there's a 5% benefit for certain outcomes when you bridge with tenecteplase, then not. But we'll have to prove that. So I think the answer to this question about bridging is unanswered. And what sort of, throws a certain other wrinkle into this is Vig's study here. Vig is a Canadian who's in Australia training with Bruce. Will come back and work with Ottawa and with us. So if you see recanalization rates, this is again, the probability of recanalization on the y-axis and time. So the typical plots, you would see that the recanalization rates with tenecteplase seems to be more than Altiplace for large vessel occlusions, and that increases with time. What is the implication? If you're actually giving tenecteplase as bridge, as drip and ship, then it's a no-brainer, right? Like it would actually open up more arteries over time. But even, at the comprehensive stroke center, there is that potentially small incremental benefit, even if, you are actually giving tenecteplase just in front, just before EVT, vis-a-vis giving Altiplace. There's also then this trial, the choice trial, that sort of, I must say, put the cat amongst the pigeons with intraarterial Altiplace. This trial was stopped early, so I must warn you that it was a trial that was stopped early. But if you actually look at what happened in this trial, so for those of you who don't know the choice trial, this was endovascular treatment. For post-EVT, you were giving intraarterial Altiplace, intraarterial TPA as Altiplace, and then comparing it to not giving it. The idea was that could potentially help with microvascular reperfusion. I think it does help with these clots that are sort of lying around in these tiny arteries. And this was a phase 2 study, and what it shows is that if you are actually giving intraarterial Altiplace at the end of the procedure, then patients seem to do better. Now, we've got to replicate these findings, but it would be interesting to see what happens now if you actually give intraarterial tenecteplase, which has more fibrin specificity and maybe a longer half-life. And so the idea that, maybe with bridging, you are actually, potentially better off when you bridge with tenecteplase. And then there's this idea that you could potentially have better outcomes with intraarterial TPA, either tenecteplase or Altiplace. And so these things need to be studied, but I'm just making the point that there is this whole idea of giving concomitant thrombolysis around endovascular treatment. And then there's this issue that EVT is not the panacea for all acute ischemic strokes. Just to remind you guys, we have around 30% of patients with large vessel occlusions, but EVT utilization still continues to be in the low single digits worldwide. There's a huge gap. EVT also can currently only be offered at comprehensive stroke centers in major cities, mostly in developed countries. And then this idea, as I was showing you, that EVT is essentially complemented by thrombolysis both before and potentially after. I just wanted to put that in context with this picture of India. So this is from 2020, and these are the comprehensive stroke centers in India. So you see this distribution. This is a country. This is from here to here is almost 3,000, 4,000 kilometers across this two. So this distance would be almost around 1,000 kilometers. So this is the distribution of comprehensive stroke centers you have. Look at the number of thrombectomy-eligible strokes, almost triple the US. 300,000, but look at the number of interventionists. So yes, we all want to work on endovascular thrombectomy, but the treatment that can reach everywhere is actually intravenous thrombolysis. So then, is there a safety concern with thrombolysis? And, in translational talks, you hear about TPA toxicity and hemorrhage and all these risks with thrombolysis. I must tell you, the ACT trial that we did in Canada was a super pragmatic trial. It is all those patients that you would normally thrombolyze in your routine practice. I'm saying in your routine practice, everybody, right, including the very elderly. We had one lady who actually wrote a letter to me afterwards. She was 102 years old. So we do have, all these patients. But if you look at the risk, symptomatic ICH risk, it's around 3.2, 3.4%, right? And so when I was training as a fellow in Calgary, I was told to quote a risk of 6% as symptomatic ICH rates. That is no longer the right number. The symptomatic ICH rates with thrombolysis have dropped substantially. Thrombolysis is safe in our patients. And this is, the NINDS trial where that 6% number comes from, right? So that number is, I presume, an overestimate. Obviously, many things have changed. We have gotten better at choosing our patients. But, there's also the effect of reperfusion. But overall, thrombolysis has become safer and safer. And so for this question, is there a role for TPA in hyperacute ischemic stroke? Thrombolysis works. Faster thrombolysis is better. Thrombolysis is becoming safer and better with alternatives like tenecteplase, which is also a TPA. Thrombolysis complements endovascular thrombectomy, and thrombolysis is the only treatment right now for hyperacute stroke for most patients worldwide. And so the answer is yes. Thank you. So I have now the pleasure of introducing Professor Nilonant Yongchai, as I call him. We are Zoom buddies, and this is the first time I'm actually meeting him in person. So, Yongchai leads the stroke program at Siriraj in Thailand, but he's also, super passionate about mobile stroke units and leads this initiative called MSU SOS. He also leads this initiative called Guiding Light for the Thai Walk, Run, Bike Fighting Stroke Initiative, and I think is one of the champions of stroke in treatment in that part of the world. Yongchai.
Thank you for your kind introduction, Dr. Menon. Good morning, everyone. Welcome to my talk. So this is my disclosure slide. All of these government organizations and also non-profit foundations. Before going to my talk, I would like to acknowledge and thank you for several organizations that have been working with us and also the whole team. Now, this is the large project and it's like a countrywide. So without their contribution, things will not go this far. So the outline of my talk will cover three things. Number one, why do we need MSU and telestroke? Number two, how? That's our experience of sharing with you and the gaps and next steps. So just a little bit of my background. I come from Thailand and working in the capital city of Thailand with the Thailand population is 66 million with the size of almost 200,000 square miles. With the capital city of Bangkok with the population of 5.5 million and the size of 600 square miles. Problem exists, like Dr. Menon says, in every country, but it's more emphasized in developing countries. It's contributed to three things. Number one is conflicting scenarios, like rural areas and remote areas, big cities but unorganized system. And also the inequity of healthcare access. Taking Bangkok, the capital city, as an example. You see, the city was divided by the Weekly Line, which is the river. So on the east side of the river, there are like 3 or 4 dots. Several hospitals can do both thrombectomy and EVT. So the red dots stand for those hospitals. But on the other way, the left side was only one single hospital, which is the hospital where I work. The Siriraj Hospital covers almost 3 million people. Can do both thrombectomy and EVT. So this is inequity. This is the data from our center. So 10 years back, 10 or more years back, stroke was on the rise, and the green line is the proportion of the patient we've been admitted in acute stroke units. So we admitted more and more, 60 to 70% of the patients in acute stroke units, and we are the center that operate on more than 100 patients per year on both EVT and TPA. Now the problem we look is at the pre-hospital, so my talk is most relevant for you who work in the pre-hospital service for stroke. So mostly deal with pre-hospital delays, lack of neurologists, and lack of efficient referral system. Again, this is the data from a single center. We lost so much of time. We lose so much of time on the pre-hospital delay. So if you look at the bar graph, it would be the green line represents the onset to door, and the blue line represents the door to CT, and the red line represents the CT to neuro time. So the green line is the pre-hospital, which take into account almost 2/3 of the times of onset to neuro times. And no matter what we do, you look at the the chart here. So we've been able to reduce the door-to-needle time to almost 30 minutes door-to-needle time, more than 5 years back. With the use of MSU SOS, it's going down to 18 minutes. Also, to emphasize the lack of neurologists, I think this happened everywhere in the world. So, total numbers of neurologists, 710. This is a few years in the past. Living in Bangkok, 450. So about 2/3 of neurologists working in capital cities. So this problem emphasizes increase in the far area and in the remote area of the city. Now the mobile stroke unit, Stroke One Stop, initiated since 2018 with the goal of it has to be increase the equity of getting access to acute stroke care. When we talking about access to acute stroke care, we mean both TPA and thrombectomy where the patient is indicated. And the workflow has to be available 24/7. And at that time, it was before the COVID era, so we want to emphasize on the use of 5G technology in acute stroke medicine and foster the use of telemedicine in emergency service. Right now, we have 7 cars owned by one hospital. So it's the ambulance with the CT scanning machine and the point of care laboratory testing and telemedicine and stroke medicine. So you can see the evolution of each unit of the car. So the first one, you can take a look at the just simply the chassis. This is the Hino chassis, and we move to the Mercedes-Benz chassis afterwards, proving that it's better. And right now, both the loading system has been evolved by working with the Faculty of Engineering, Mahidol University. We changed many things, many parts, and right now we are MSU 7, which is launched this year. So this is my best friend, Gustavo, who visited us, who's just sitting here. Now this is the MSU SOS workflow. So patients who have the symptoms of less than 4.5 will call the National Emergency Number 1669 and 2 units working together. So the regular EMS and the MSU SOS regular EMS going to pick up patient at the home, and the mobile stroke unit will be operated by the hospital who own the unit and see each other at the rendezvous. And then the operation started. Patient will be moved to the MSU and scanned and then treated accordingly to the guideline. The operation has started before the COVID, so we strive before the COVID, and the workflow was tested during the COVID. So 4 people will be on board: the driver, the nurse, the MDs, and also the technicians who operate the CT scan. And you can see they work very effective. So this patient presented with speech difficulties. We're going to give TPA after seeing, so everything will be real time. You can see the evolution. So right now we have several platforms. We bring the car to the remote area of the country, and they can remote to us. At the same time, it doesn't matter how many cases they are activated at that moment. We can deal with several activations at the same time. The purpose of the MSU SOS is, number one, it was designed to be one-stop service for all. So CT, CTA, instant access to vascular neurologist teleconsultation, and shortening into hospital transfer. That was the ischemic stroke. When talking about intracerebral hemorrhage, it's not very often that we see patients who was on anticoagulate who need a PCC, but we have also the PCC on board, and it did make a significant difference. So this patient has the POCT INR was 6.9, and she was taking warfarin, and scan was performed in the car, and PCC was given, and then brought her back to have the surgery. She is not that bad, so MIS of 3. We were able to convince the payer, the government to pay for each operation a certain amount of money, but not the whole cost. So there is a consultation for specific disease, specifically talking about acute stroke on the MSU service. And the operation was also certified by the accredited by TEMSA organization, which also responsible for the emergency service in Thailand. How about the evidence? This is our experience. Right now, we can accumulate, so almost 1,600 patients that we are on service. And you can see each different bar represents each different site. So I want you to focus on the red and the pink that was the door to CT and CT to needle, because we can control is the standardization of the operation. For the blue and the orange, that was the onset to activate, that was on the patient part, and activate to draw, that was on the distance. The time required on the orange depends on how far the patient was living, because it was in different side of remote area. Okay? So we were able to control the door, which means when the two cars meet, we counted the first meet was the door time, and the needle time was the minute the TPA was injected. So it was quite more or less the same without any significant difference. Now this is the type of diagnosis. So in total, there was about 12% of stroke mimics. So every 100 cases that we was called, about 12 cases was stroke mimics. And about half of the patients in acute ischemic stroke will receive reperfusion therapy, including both IV TPA, IV TNK, and or EVT in all the centers. So the number was increasing. Like Dr. Menon says, the IV TPA was underutilized, but this guy will will emphasize the use of, will increase the use of thrombolysis. Unfortunately, this is not the same. The result of this is not the same as previous publications that they can increase the TPA time, the onset to needle time, within 1 hour, the first 1 hour. In our system, it was less than 2%, and this is probably due to the patient awareness or ineffective referral system of the first hospital. We compare 3 groups. Interestingly, at the same time, in a single center setting, we compare 3 groups who come to the service of acute stroke, combining so the combination of MSU through 250 approximately. Patients who come with the EMS 214 and patients who walk in 521. And compare with all the features that the patients received and the chance of getting TPA and reperfusion therapy. So the baseline characteristic was more or less the same, except for the initial NS stroke scale score, which was a bit less on the MSU, and the rest are more or less the same. We found 3 things. Number 1, according to time measures, door to CT was least with the MSU service when compared to the EMS. So you can see the median time was 6 compared to 12 and 13. Onset to needle time, 126, 127, 121. This is not significant difference. I have told you previously. Door to needle time was less with 18, 26, and 31. I suppose that it was diluted into the pre-hospital settings of the patients to come to the door time. So door to puncture time also less in the MSU group, 68, 80, and 92. And the 3-month modified ranking score, it was best in the MSU group, 70%, 50%, and the 62% accordingly. After adjusted, the odds ratio of getting reperfusion therapy was more on the MSU. So in other words, the patients who come with the MSU service will have triple the chance of getting reperfusion therapy, either TPA and or thrombectomy. Patients who come with MSU compared to EMS was about twice as much that received reperfusion therapy. Now, when looking at the clinical outcome, mode of hospital arrival, so patients with MSU, after adjusted for everything, including the NS unequal of the NS stroke scale score, patients with the MSU group have twice the chance of getting back to good recovery. Now, this getting according into previous studies of the this is the pool analysis of 3 or 4 major trials. So better excellence outcome, the odds of getting better excellence outcome was almost 2. Same thing with association with the chance of getting thrombolysis, almost 2 odds ratio. But the only thing that is not going to the same direction of our study was the proportions of golden hour intravenous thrombolysis in the, this is affected by 2 major trials, one from Germany, the other from the US, which is developed countries. So the infrastructure of getting notice of getting stroke is completely different from developing countries. Now, what's the gaps and next step? These issues are always discussed when we talk about the MSU services. The cost of MSU, like you know, is almost about $1 million US. The cost effectiveness is still the problem. Cost and size of CT machine, there is debatable between shall we use the small one or use the whole CT, whole body CT. It depends. Geographic factors, we are conducting a study looking at where is the best rendezvous in each demographic area, and it's in the thesis of our PhD students. Expand the use of the MSU, shall we move to, instead of using in the area of stroke, shall we move to the traumatic head injury just to increase the chance of using the MSU to make it more cost effectiveness? These are direct advantages of MSU implementation, which you already know. So I won't spend so much time talking about this, but I will emphasize on the indirect advantage with our experience when we get into the locals. So to inspire and create momentum shift for the whole local stroke team, to engage patient, society through concrete example, is very concrete of what can be done in acute stroke treatment before giving them the knowledge of stroke prevention. To draw resources that do not exist in the healthcare system, this is very important. I will elaborate to you later. To initiate the use of telemedicine and to solve the shortage of neurologists. This is what's happening when we get into the field. So people get excited, they even celebrate. The monks, you see the monks will come, the police officer, the military man, everyone comes and help each other. So this is what I say is indirect advantage. So it drives the whole village, the whole locals into the same direction, and that gives you the opportunity of give them the knowledge and also closing the gaps of stroke awareness. So we have the model of scan, treat, refer in one stop, and we put 3 things together. So air ambulance and the regular ambulance and the MSU ambulance. And we even can draw the famous people to help us. So this never been explored. What about next? So in collaboration with, we work closely with major organizations, Ministry of Public Health, the foundation of the Crown Prince Hospital, and our university, Mahidol, Faculty of Medicine and Faculty of Engineering, the EMS services, trying to expand. So we use the celebrate. So next year is the 72 year of celebration of His Majesty the King, and we already talked that we will put the MSU into the Crown Prince Hospital, which is situated in remote area, 21 hospitals across Thailand. So 4 in the north, 9 in the south, northeast, and 2 in the middle part, and 6 in the south. So with that, together with the number that existing today is almost 30 MSU SOS operation across Thailand, and this is to close the gaps of the remote area that is lack of several shortage and to decrease the inequity of getting access to the MSU SOS. So I will present to you another side of the coin that you can use not only the MSU SOS for the just treatment of the pre-hospital, but for the like a dart that pierce into a piece of stone and introduce the acute treatment together with pre-hospital awareness of getting acute stroke to be aware by local people and increase them the stroke prevention. So in conclusion, MSU and tailored stroke strategies help expedite structured pre-hospital thrombolysis and streamline inter-hospital transfer process, thus reducing time and improving clinical outcome. And it can be implemented in any underserved area in the developing world or in highly populated area which delay access to tertiary stroke centers. And thank you very much.
Thank you, Dr. Neerman. So our next speaker is Dr. Gauss Ptolemus. He's from University Medical Center, Hamburg, Emmendorf. He's the PI of the Wake Up trial and using the DWI-Frail mismatch and to extend the thrombolysis within outside 4.5 hours in Wake Up patients. And his topic today is use of advanced imaging for thrombolysis in patients with stroke upon awakening. So please.
Yeah, thanks a lot. So we heard a lot about drugs for reperfusion treatment, about pre-hospital organization. Now it's about imaging. Here you can see my disclosures. And if we talk about imaging to guide intravenous thrombolysis, then we have actually two different settings. We have the early known time window, which you all know. In this situation, we just rely on the information about time of onset. And then we have the situation of mostly stroke upon awakening, but also other situations of unknown time of symptom onset. And then we have to rely on imaging. And that's what I'm going to talk to you now about the next 15 minutes. You all know this, and you've heard it before by Bijou's talk. IVTPA is very effective within the first 4.5 hours, and with regards to imaging, you just have to exclude hemorrhage, and usually this is done by CT, sometimes also by MR, but there is no further requirements to imaging if you want to start IVTPA in these patients. But this is different if we look to the unknown time window. And then in this setting, we have actually two different concepts how we can use imaging to guide intravenous thrombolysis. And the first one is to use imaging as a biomarker of tissue that can be saved by reperfusion. It's on the left side here, so that's so-called penumbral imaging, which has been originally introduced with MRI by perfusion-diffusion mismatch, but also can be done by perfusion CT with a mismatch usually between time Tmax and cerebral blood flow, so different perfusion parameter maps. This is the one concept, and the other one is the one that we used in the Wake Up trial, is to use imaging as a surrogate marker of lesion age to identify those patients who actually also time of symptom is unknown, are still within the time where thrombolysis is effective. And this is the DWI flare mismatch, and I'll introduce both concepts a bit more detail now in the next minutes. So here you can see a typical example of a penumbral imaging. In this case, based on MRI, you see here the DWI map with a small, he colored in red, small infarct core. So this is the tissue that has already been gone to infarction mostly. And you can see here the perfusion map colored in blue now. This is the entire area with a severe hyperperfusion, in this case based on an M1 occlusion. And now if you calculate the mismatch between the both, you have the green area. This is the tissue that can be saved, and in this patient was saved after successful intravenous thrombolysis. This is the flare image at day 1, and you can see only the tiny small final infarct, all the rest was saved. And by this type of imaging, you capture patients no matter what real time has passed in a time point of stroke evolution where they still may benefit because there's a lot of tissue that can be saved. And if you nowadays do this imaging for example, using commercial software, then the maps you get look like these here, the DWI lesion marked in purple, and in green marked the perfusion lesion, and in this case it was a clear mismatch volume by 57 mils, and this was a patient that of course qualified for intravenous thrombolysis even though time of symptom was unknown. Now the second concept relies on the difference in visibility of different MRI, of the lesion and different MRI sequences. And you can see here the gray boxes, they are to represent neurons, and you all know that within minutes of acute vessel occlusion and hypoperfusion, there's cytotoxic edema, which results in cell swelling, and this is the underlying phenomenon that we can depict by diffusion imaging. And you can see here within minutes, the acute ischemic lesion becomes visible as a hyperintensity on DWI, but at the same time, FLAIR or T2 images, which rely on visualizing edema, still looks normal in this area. This changes over a few hours, then we have net water uptake, ionic edema, and this is all what then results in a parenchymal hyperintensity on FLAIR or T2 imaging, or also on CT actually. But so if we have this pattern, a visible stroke lesion on DWI, but no marked parenchymal hyperintensity on FLAIR, then that's what we call DWI FLAIR mismatch, and these are patients which are very likely to be within the first hours of stroke, and that's why might benefit from thrombolysis. And this is what we used to identify patients for treatment, for randomization in the wake-up trial, and here are just two examples of typical DWI FLAIR mismatch, and you can see how easily this can be assessed in clinical routine. Clear DWI lesion, no marked parenchymal hyperintensity, and I would like to point to the fact that it's not about any slight changes there, it's about a marked hyperintensity. And this is a clear mismatch pattern here also, so these patients are patients that likely benefit from thrombolysis, as the results of our trial have shown. Well, these are two other examples, and here you can see what I mean with a marked hyperintensity. You can see here the FLAIR hyperintensity virtually reflects the DWI lesion, and the same here. So these patients are likely to have a stroke that is more than 4.5 hours ago and would not have been randomized in wake-up and likely will not benefit from thrombolysis. So now what do the trials say about the two imaging concept applied for guiding IVTPA in unknown onset stroke? Let's start with penumbral imaging. The Extend trial has used penumbral imaging based on CT or MRI to randomize patients with either late stroke onset, between 4.5 and 9 hours of symptom onset, or unknown time of symptom onset, to treatment with Altiplace or placebo. And in order to be eligible, they had to present a penumbral pattern, as I've shown before. 225 patients were randomized, and the trial was positive, so the likelihood of favorable outcome was higher in patients treated with Altiplace with an odds ratio, adjusted odds ratio of 1.44. You can see here the MRS scales showing a better outcome in the Altiplace patients as compared to placebo. And this was really an important trial because it was the first trial demonstrating efficacy of intravenous thrombolysis beyond 4.5 hours based on penumbral imaging. There has been numerous observational studies or smaller pilot studies over the past 20 years, but only Extend finally gave evidence that this works in a randomized controlled trial. And you see here it's a trial of also late time window, but I refer to this in this talk addressing unknown onset stroke because the majority of patients actually in this trial were patients with unknown time of symptom onset, so about 2/3 of patients. So essentially it's more or less a trial of unknown onset stroke treatment. And also of note, the trial goes back some years, and at that time thrombectomy was not routine practice in most centers worldwide. And you see here that more than 2/3 of patients presented with large vessel occlusion, and nevertheless IVTPA worked in these patients. So then the researchers from Extend also did a meta-analysis including ICAS-4 Extend, so which was sort of the European companion trial, and the earlier Epithet trial, and this with a slightly higher number of patients confirmed the results. There was an improved number of patients, improved exit functional outcome in patients treated with Altiplace with an odds ratio of 1.86. And a clear benefit of this treatment. And the benefit was clear, especially in patients who presented with this penumbral mismatch, while in the smaller group, which had no perfusion mismatch, there was no clear treatment effect visible. That's the underlying reason why actually we need this advanced imaging to identify those patients who benefit. And of course, like in all thrombolysis trials, symptomatic intracranial hemorrhage rates were slightly higher, but nevertheless, the net benefit of TPA was significant. And again, very interesting, like with all TPA trials in the known time window, there was consistent benefit across all important subgroups, across age groups, and also across strata of different types of vessel occlusion. It also worked in the large vessel patients. Now, so much for the penumbral imaging. I'm going to the wake-up trial now, which used the MRI pattern as a surrogate of lesion age, and wake-up randomized patients, if they presented this pattern I shown you before, the DWI flare mismatch, to treatment with Altiplace, standard dose, or placebo. The primary endpoint was the same as in all earlier TPA trials, MRS 0 to 1 at 90 days. We also looked at secondary endpoints like the shift analysis. So 503 patients were randomized, median NH is 6, so a rather moderately affected population. And you can see here the main results. Treatment with Altiplace had a beneficial effect on outcome. Outcome was better in those patients randomized to Altiplace with an odds ratio of 1.61. And this was held true for the dichotomous outcome of excellent favorable outcome, as well as for the shift analysis with a better outcome across the entire range of the MRS, which you can see down here. So the main conclusion is that MRI-based thrombolysis in unknown onset stroke is beneficial and is safe if we use the DWI flare mismatch to identify patients. We also did a pooled analysis integrating all randomized trial data of patients with unknown onset stroke, assessed by or included by advanced imaging, so both penumbral imaging. We included the extent and ECS4 data, as well as the DWI flare mismatch, and for this we also included data from THORS, a Japanese trial which followed the wake-up criteria, but just using the Japanese dose of TPA for treatment. And so we had more than 800 patients in this analysis, and actually the results were very much the same. It confirmed that there's a benefit across the entire range of the MRS with treatment with Altiplace over placebo if patients are selected by either penumbral imaging or DWI flare mismatch. Well, and I mentioned before that in extent, a large number of patients had a large vessel occlusion. This was the same in wake-up, also a trial done during a time where mechanical thrombectomy was only used in selected centers. And we had about 100 patients with LVO, so 1 in 5 patients. And also in these patients, of course, outcome was worse than in the entire population, but there was a clear benefit of intravenous thrombolysis. They did not receive thrombectomy at that time, to keep this in mind. Of course, nowadays they all would go for thrombectomy, but we almost doubled the number of patients with a favorable outcome just by thrombolysis alone. And if we now look at sort of the other end of the spectrum of stroke, the lacunar stroke, usually mildly affected stroke with small lesions, again, from wake-up we could see that treatment with intravenous thrombolysis has a benefit in these patients, which has been a debate over several years in earlier days. You can see here just 2 examples, clear lacunar stroke here in the thalamus or in the brainstem. These are examples from the trial, and we had 108 patients with a clear MRI-defined lacunar stroke. Again, here the outcome, the treatment benefit was very much the same. Of course, here now overall better outcome than in the LVO patients, but a plus 12 absolute increase of patients with a favorable outcome in lacunar stroke. So TPA works for the large vessel occlusion in unknown onset stroke. It works also for this very small lacunar infarcts. So we need, based on these trials, either penumbral imaging with perfusion imaging or MRI with DWI flare mismatch. But what if this is not available, or if you just want to rely on the simple plain CT? And then I would like to ask you, just take a look at 4 CTs taken from clinical practice in a high volume, high quality center. It's hard to judge both infarct core or potential tissue at risk in these images. So if it's unnecessary, I would rather not rely on these images to guide IVTPA in a unknown time window, if I have available the imaging parameters that I showed you before. But of course, there are situations where this is not available, and there is a trial who tested this actually in unknown onset stroke, which is the TWIST trial. This is different a bit from the earlier trials because it used a different drug, Tenecteplase, but we've heard before that Tenecteplase at least seems to be non-inferior, maybe even a little bit better than Altiplace, so this should be no downside for TWIST. The trial also was a bit problematic because, of course, it was a more recent trial. Thrombectomy was available and thrombectomy was allowed, so this may have a number of patients underwent thrombectomy, which may have diluted the effects and the potential group difference in this trial. But anyway, the key aspect of this trial was they relied on plain CT, excluded those with very large early ischemic signs, and if those large signs were not present, they were randomized in unknown onset situation to tenecteplase or placebo. The trial randomized almost 600 patients, and here you can see the results. The upper row is the tenecteplase. This is from the original presentation of the trial earlier this year at ESO conference. There seems to be a slightly better outcome in the tenecteplase group than in Altiplace, but the statistical analysis was neutral. So the p-value and the CD odds ratios, the confidence intervals crossed 1. And this is sort of a pity because maybe the trial was just underpowered or they did something different as the people in Extend. Because if you just look at this, the mere numbers, and I put the Extend outcome slide here, they are not that much different. So if you see like 5% or 6% absolute benefit in MR 0 to 1, this is very much the same as in tenecteplase, but Extend luckily was positive. So maybe in TWIST they just would have had to randomize 200 more patients. So I would not say that this trial was negative. It just shows that if you use plain CT to guide IVT-PA with tenecteplase in an unknown time window, maybe the treatment benefit is not as high as in the highly selected populations based on advanced imaging, but I think it opens at least the perspective to further trials studying this. So now one question that comes up if we look at especially perfusion imaging, that this may appear confusing to those who are not dealing with this every day. So there are so many parameters: cerebral blood flow, cerebral blood volume, mean transit time, time to peak, Tmax, whatever. And there you can look at absolute values, at relative values, and there are different thresholds that are given. So you can easily get lost a bit, and it's so easy then to rely on a simple software that just presents you very clear maps and even numbers, counts of mils that can be saved. So the question is, do we need this to guide intravenous thrombolysis and unknown onset stroke? So I would say forget about all these different complicated things. In clinical practice, actually it doesn't matter that much. That's my experience. There are two parameters that are best established. It's Tmax, more than 6 seconds, and a relative CBF, less than 30%. But even if you look at other parameters, in the end, the pattern usually is quite clear in those patients. So my response would be clearly no, you don't need any commercial software or complicated analysis. Just look at the images. In clinical practice anyway, you should not count mils, but you treat the patient based on the imaging information that you have in a clear pattern and also the clinical setting, of course. So with this, I'd like to come to my conclusion. IVT-PA is safe and effective in unknown onset stroke, for example, in wake-up strokes, which are the most of these patients, if you have DWI flare mismatch or a penumbral pattern on MRI or CT. And in this, it improves functional outcome as well in patients with a large vessel occlusion, but also in those with a minor stroke or like a Kuhner stroke. The type of imaging that you need to guide IVT-PA in your clinical practice depends on the time window. So for the late time window, based on the trial data we have available now, you need advanced imaging. And this is also in line with the recommendations from international guidelines. And this at the end of my talk, and thank you a lot.
Thank you, God. It's my pleasure to introduce Dr. Jovin, or Professor Jovin, or Tudor as I call him. With him, it's always a question of which trial is he not the PI of with endovascular treatment. So he's the PI of almost, all of the trials in EVT that you know of. Tudor is also a close friend of the Calgary Stroke Program. So Tudor.
Thank you very much. Thank you for inviting me to speak. And since there's so many publications, we've been so lucky, and we've had such a great year since last WSC. I just decided to stick to the trials that are related to thrombectomy. These are my disclosures. So what questions have been addressed in this last year. So number one, does thrombectomy in patients with large core improve patients' outcomes? Is advanced imaging, MRI or CTP, and we heard about that just now, for IV thrombolysis selected patients, necessary to select patients for thrombectomy in the 6 to 24-hour time window? Does intravenous thrombolysis improve outcomes when administered prior to endovascular therapy in patients presenting directly at endovascular centers? Does intravenous thrombolysis improve outcomes when administered prior to endovascular therapy in patients treated in the late time window? And does the combination between endovascular reperfusion and neuroprotection with nerinetide improve patient outcomes? So let's take the large core question. We have SELECT-2 trial. The key inclusion criteria were an NIH stroke score greater than 5, time window of 0 to 24 hours, and an aspect score of 3 to 5, or core greater than 50 with no upper limit by CT perfusion or MRI. The main findings of this trial, as outlined here, is mechanical thrombectomy improves outcome without effect on symptomatic hemorrhages or mortality. And relevant additional studies, I cheated here a bit. I introduced another sort of supporting study in these 5 main studies, is TESLA. In subgroup analysis of SELECT-2, very interestingly, there was no treatment effect modification with regards to time window, but also very surprisingly, perhaps for many of us, no treatment effect modifications with regard to infarct volume, and also with regards to the presence of mismatch. As I mentioned, I'm introducing a bit the TESLA trial, which has not been published but has been reported. This was an aspects 2.5 only, which is the inclusion very similar to SELECT-2, but imaging only based on aspects on a non-contrast CT scan with a maximum of 300 patients enrolled. The primary outcome did not reach statistical significance. It missed the primary outcome, and it missed many of the secondary outcomes as well, but it was incredibly close. And on the 90-day modified ranking 0-3 in specified subgroup analysis, this study was positive, but of course the primary outcome was missed in this trial. With a delta of 10% in patients on the modified ranking 0-3. And what I think is a bit counter to what SELECT-2 has shown, here the point estimates, the treatment effect heterogeneity is not there, but the point estimate is very different in patients treated in the very early time window versus the later time window. So I would think that TESLA sort of supports the findings of SELECT-2 that mechanical thrombectomy improves outcomes in patients with large cores. The remaining questions are, is there benefit in patients with advanced age in the extending time window, and the patients with the largest infarcts, aspect 0-2, or core greater than 150 mLs, of which there were very few patients in SELECT-2. And I think the implication is that baseline infarct size should no longer be a reason to exclude patients from thrombectomy. Angel aspect is another one of the 5 that I'd like to highlight. Dr. Chong is actually one of the authors of this trial. It had similar inclusion criteria, went up to 24 hours. You know that most of these trials did put some limits on patients' age as well. Aspects 3 to 5 or core 70 to 100. The main finding, as outlined here, is that mechanical thrombectomy improves outcomes with some trends towards increased symptomatic hemorrhage rates in treated patients, but no effect on mortality. An additional relevant additional study is tension, which we'll hear about tomorrow. Again, the remaining questions are the same. What is the benefit and cost effectiveness in patients with advanced age in the extended time window in the 6 to 24 hour and the largest infarcts? To me, this large core story becomes very similar to treating patients even with moderate core or small core that are very old. Age is a poor prognostic factor, but it's not a treatment effect modifier. And we have to understand a bit and refine these indications, but certainly baseline infarct size should no longer be a reason to exclude patients from thrombectomy based on these trials. Again, secondary analysis, subgroup analysis pre-specified from angel aspects suggest that there is no treatment effect modification with regard to time or infarct size. And I want to again mention tension, which will be reported tomorrow. I don't know the result. I don't know whether it's going to be published at the same time. I think just the fact that it's presented here, that counts for a publication. Stay tuned. Tomorrow, Dr. Tomala will present the main results, and we will see whether these trends still continue. And also, the following week, during the SLICE meeting, we will present, I'm privileged to be one of the co-principal investigators of the LASTED trial, which is an early time window trial with no limits on the aspect score. I can tell you there's about 100 patients who have an aspect of 0, 1, or 2 by MRI with baseline infarct volumes of 150 cc's. I don't know the results. We haven't closed the database yet, but I think this will be another very informative trial in terms of telling us whether even these giant infarcts at baseline benefit from thrombectomy. So stay tuned for next week. It's going to be during SLICE, which everybody can log into the meeting. So number 2 question is, do we need advanced imaging, MRI or CT perfusion, for late time window treatment, thrombectomy? This is the Mr. Clean late trial published in Lancet this year. The key inclusion criteria were an NIH stroke score greater or equal to 2, window, of course, 6 to 24 hours, and no requirement for advanced imaging. In fact, these are all patients who do not meet criteria for dawn or diffuse, and all they have to do is have good or moderate collaterals on the CTA. The main finding is that mechanical thrombectomy improves outcomes. Treatment effects are very similar. Just in the large core story, the treatment effects are very similar with what we've seen in the early time window patients or patients who were treated with advanced imaging in the extended time window. There was a higher incidence of symptomatic hemorrhages in the treated patients, but trends toward lower mortality with mechanical thrombectomy. And an additional, relevant additional study, I would say, is the study that was published within the last year, that was conducted in the UK, where patients are not treated outside of regular hours, period. Nobody gets treated. And they select patients for thrombectomy based on aspect scores only. So they had, if you want, a mini randomized trial because patients who were presenting out of hours were not treated. So they had the controls, the non-treated patients, versus the treated patients who were treated during regular hours. And these patients were all selected based on an aspect score. And here the numbers are very similar to dawn. There is a statistically significant benefit in favor of lower mortality in patients treated with thrombectomy, again, based on an aspect score that is greater than or equal to 6, and a statistically significant difference with regards to shift analysis. So that support the Mr. Clean trial. I would say the remaining questions are, is there benefit based on aspects only? I don't think we've proven that in a randomized trial. In a proper randomized trial, there is a trial underway in Brazil that aims to answer this question. And is there benefit beyond 24 hours? The implications are that advanced imaging, CTP or MRI, are no longer necessary to select patients in the 6 to 24-hour time window, in my opinion. The other question is, should we give intravenous TPA in patients presenting directly to an endovascular center? This is the IRIS meta-analysis published in The Lancet this year, relatively recently, I think a month or two ago. This is an individual level patient meta-analysis, 6 randomized trials, 2,313 patients that were all enrolled in trials aiming to answer the question whether TPA should be administered prior to thrombectomy. These were randomized patients that presented directly to thrombectomy centers. This is not a trial of transferred patients. The main finding was that at the 5%, at the pre-specified 5% boundary for non-inferiority, non-inferiority of skipping IVTPA could not be demonstrated, nor could be superiority of TPA demonstrated. There probably is a benefit, a treatment effect in favor of TPA, but is small with a number needed to treat of 57. I think a supporting trial, because the next question is, after we see all this data supporting TNK over TPA, and you've heard about it earlier from Dr. Menon, does it make a difference if we use TPA versus TNK? This is the subgroup analysis of the primary outcome of the IRIS meta-analysis. And you will see here it's very interesting that there is treatment effect heterogeneity with regards to time to treatment. The third tertile, 71 to 77, 734 minutes from onset to randomization. So with time, there is a decline in benefit. And in the 3 to 4.5 hour time window, this benefit is unclear whether it remains. With TPA, we don't know whether that's the case with TNK. And another interesting subgroup with trends toward heterogeneity in treatment effect is the large core. Of course, these patients were not supposed to have a large core because at that time there was an exclusion criteria, but some of these patients had a large core. And in those patients, it looks like it's possible that endovascular treatment alone is better. The ACT subgroup that was pre-specified and specifically geared to answer the question, is TNK better than TPA prior to thrombectomy? There was a study run by Dr. Menon as the principal investigator of ACT. And the answer was there was no significant difference between TNK and TPA prior to thrombectomy. Again, this is a pre-specified subgroup. Whether we need a randomized trial specifically designed for that, it's not clear to me, but there are some that are already ongoing. So we will find out about that. How about value of, so in terms of remaining questions, again, would the results be different if TNK was used? What about large cores? Should we administer IV thrombolysis in patients with large core based on the subgroup analysis from IRIS? And then the time window. But the implication is that IV thrombolysis is here to stay. It's better for the majority, but I think that individual decisions would be increasingly adopted, especially in the later time window, patients with large core. Some of us would even say in patients with tandem occlusion, where we are anticipating the use of additional antithrombotic agents, antiplatelet therapy specifically, although the data doesn't pan out at all in favor of skipping IV TPA in this circumstance. So how about beyond the 4.5 hours time window for intravenous thrombolysis? Is there a role for TNK prior to thrombectomy? This is the Timeless trial. It has not been published, but I think it counts. It was presented at ESOC. It's published as an abstract. It's a very important trial. This trial randomized patients to tenecteplase 0.25 milligrams per kilogram versus placebo in patients presenting either at the mothership or transferred, who were transferred for thrombectomy. This study was completely neutral. There was no benefit of TNK prior to thrombectomy. These are all patients who had to have a mismatch. They were treated within 4.5 or randomized within 4.5 to 24 hours with an NIH of 5 or greater. And the IRIS sub-study, which I didn't have the slides of, but was also reported at ESOC, is kind of converges with IRIS, and I would say with the results of Timeless as well, showing that the benefit of intravenous thrombolysis prior to thrombectomy is only very early, and that at about up to 2 hours and 15 minutes, this benefit becomes null. So again, it's something that supports the findings of Timeless, that where no benefit of TNK in addition to thrombectomy was found in this late time window. So the remaining questions to me is, should we be using, is TNK the different drug for these patients? Should we be using different lytics or microcirculation agents or neuroprotection as opposed to TNK in these patients? And the implications is, in my opinion, IV thrombolysis, whether TPA or TNK prior to mechanical thrombectomy, is unlikely to be adopted in the late time window, certainly with TNK or TPA. And then finally, this is again not published, but will be presented today. I'm very, very excited about this because I personally am a big believer in the combination neuroprotection and reperfusion. This is the ESCAPE Next trial. Everybody knows about ESCAPE NA1. This was a negative trial, presumably because TPA inactivates nerinetide. So ESCAPE Next has used very similar inclusion criteria, 0 to 12 hours, age 18, aspects 5 to 10, and importantly, no IV TPA. The main findings, I have no idea. I'm very excited and very curious to know, but we will know later today. And a relevant additional study is Frontier, which also uses nerinetide. It's an ultra early use in the ambulance. Preliminary data. This is a slide Dr. Timiansky was kind enough to give me a while ago, but it showed that preliminarily in the first group of patients where this was looked at, just like in FAST-MAG, it was possible to give the drug at a median of 59 minutes. So it's possible for us to administer these drugs very early, and whether this drug is the right drug and will lead to better outcomes, we will find out today. The remaining questions, regardless of the results, is there benefit of other neuroprotectants, other approaches? There's multiple mechanisms of ischemic injury. Nerinetide basically addresses excitotoxicity. There's a lot of other mechanisms at play. Should we use cocktails in the future? Is there benefit for other neuroprotectants, etc.? The implications, I predict, especially for the ones who believe in the combination neuroprotection and reperfusion, are going to be profound, because If this trial is positive, or the two trials are positive, I think will open up the whole world of neuroprotection. There will be probably a lot of new compounds, new trials, investments coming in. On the other hand, and I hope that's not going to be the case, but we'll find out. With negative results, I think we will remain with a nihilistic approach that we've been plagued with in this field of neuroprotection for the last 20-something years. So in summary, I would say the questions that were addressed: does thrombectomy patients with large core improve patient outcomes? The answer to me is yes. Is advanced imaging, MRI or CTP, necessary to select patients for thrombectomy in the 6 to 24-hour time window? The answer is no. Does intravenous thrombolysis improve outcomes when administered prior to endovascular therapy in patients presenting directly at endovascular center? It's possible, but the effect size is small. The number needed to treat is 57, according to the IRIS collaborators. Does intravenous thrombolysis improve outcomes when administered prior to endovascular therapy in patients treated in the late time window? The answer is no. And does the combination between endovascular reperfusion and neuroprotection with nerinetide improve patient outcomes? I don't know. We'll find out in a couple of hours. Thank you very much.
Thanks, Tudor. We have time for a few questions. Can I request God's young child, Tudor, please?
Okay.
Please introduce yourself. And
Peter Schellinger from Germany. Great talks. Thank you very much. Peter, I have a question more asking for your comments or your views on that regarding TNK, where the database gets more and more convincing, and a shift is likely to occur depending on what a test 2 will show tomorrow, I think. But there are still issues with the label and therefore reimbursement for TNK that needs to be changed. At least in Europe, we only have 50 milligram vials. I don't know about the Americas. So we need to open one vial that would serve 2 patients and throw away 1 dosing if there are not 2 patients simultaneously that we could treat. So we need new vials. And number 3, in contrast to TPA, and you may even correct me, TPA doesn't have any biosimilars. TNK has, as far as I know, up to 7 or 8 other drugs that bear the same name and are more or less similar with the original drug. Is that an issue that we need to take care of, in your opinion?
Thanks, Peter. All comments well taken, but all point towards how things can improve in the future, right? So, as the companies will tell you, supply side issues are being corrected, vials are being possibly, tailored to needs. Regulation is being addressed. So these are issues that are being tackled. So, the future seems quite optimistic. I may have missed the second part, but go ahead.
Yeah, my question is towards Dr. Jovin. A couple of weeks ago, the BUS trial was published in JAMA Neurology with a compound from Chinese celery, nibutyl phthalate, I think, if I'm spelling that correctly, showing extreme efficacy in patients treated either with intravenous thrombolysis alone, or with mechanical thrombectomy alone, or with bridging therapy. Any comments on that?
Yeah, thank you. I mean, this is a compound that is made out of celeriac root, and maybe Dr. Chong was part of the study, because I think some of your colleagues at Tiantan were part of it. I'm not sure, but I think we're seeing several other approaches that are beneficial. We have to see what the regulatory agencies are going to say about it. My guess is that they're going to want these results reproduced on U.S. populations for FDA approval or European populations. That's usually the norm. Along the veins of what today's presentations will open up, I think that we're going to see a lot of these approaches being presented and being promoted, and we're going to see a lot of positive trials, and we're going to have to, number one, determine what makes most sense to use. Can we use them as cocktails? And this drug was basically shown to be beneficial in conjunction with reperfusion. We know, and there's been a lot written about why other neuroprotectants in the past have not worked, because they were not used just the same way they were used in animal models, which is in conjunction with reperfusion. Now we have the MCA occlusion, or reversible MCA occlusion model in humans, and I suspect that we're going to see a lot of positive compounds in different trials, but I think we're going to need several trials to confirm benefit. But yes, we all hope that we're going to transform fast progressors into slow progressors by time, etc. It could be a revolution in the field.
Thanks, Tudor. Please introduce yourself.
Oh, hi, my name's Lily Jo. I'm from Canada. Questions for Dr. Tamala. One of the things that I've always found super interesting about the Wake Up study is that almost all of the secondary endpoints was positive except for the DWI volumes at 72 hours. So why do you get that significant functional benefit without changing infarct progression on DWI?
Yeah, this is an interesting question. We also discussed about this a lot, but interestingly, it's not the only trial with this phenomenon. So no effect on surrogate marker, so lesion marker of infarct size. I think the DEFU-3 had the same result, but a clear clinical benefit. I think there are different parts, the explanations to this. First of all, the timing of measurement was quite early. It was about 18 to 30 hours, so 24 hours in the mean. And there is infarct evolution beyond that, which we know quite well. And then, of course, especially in Wake Up, the infarcts were very small. You've seen the examples of the lacunar stroke. This were 108 patients with infarcts less than 1 or 2 mils. So it's difficult to do exact measurements there. So I think it's a mixture of this. And we don't have any doubt on the fact that the lesion itself and the effects of the lesion on behavior are the underlying substrate of treatment benefit.
Hi, it's Steve Davis from Melbourne. Thanks for all excellent discussions. Tudor, my question's for you. There's overwhelming statistical benefit of thrombectomy out to 24 hours, but sometimes treatment is futile. In your own practice, what criteria would you use to exclude or advise against thrombectomy out to 24 hours? Or do you treat everyone?
You mean beyond 24 hours or within 24 hours?
Within 24 hours.
Within?
Yep, where thrombectomy clearly has statistical value in all the trials. When would you regard treatment as futile? What criteria would you use?
Well, can I answer this question after the tension presentation tomorrow? So, my personal feeling, and that's kind of, it's not necessarily, you're right that what we've presented with what has been shown so far, I think, it looks like there's benefit in all these patients, but for instance, in Tesla, I think there is, once you go lower down with the infarct size, perhaps there is some lack of effect, if you want, in the, outside of the ultra-early time window. I do believe that in the ultra-early time window, we should treat everyone, yes, for 2 reasons. I don't know the results of LASTE, but if that is, we'll have to see what that shows. But even that, these patients are very few and far between. A giant, an aspect of 0 or an aspect of 1 within 6 hours. So in order for us to waste the time to find out how big is the infarct, we're delaying reperfusion, and will have a negative which will have negative repercussions on the vast majority who we know benefits. So I think that in the early time window, I personally feel that we should treat everyone. Not that we should treat everyone. If the patient is demented and doesn't have a good quality of life, or if they have terminal cancer or whatnot, but this infarct size should not be the what makes us treat versus not treat, right? Or we could use it as a prognostic tool. In the beyond 6 hours, 6 to 24 hours, I'm not yet convinced of that. I think perhaps we need more data.
Thank you.
Gus.
Thank you. Thank you. My name is Gustavo Zaposnik. I'm one of the stroke neurologists here at the University of Toronto. So thank you very much for all great presentations. I think that this morning we learned about, the evolution of different trials with different time windows of different agents or different strategies about improving patients' outcomes. Now, my question is for the table, but primarily even for Bishoy. I will do a provocative question, Bishoy, for you to learn about your vision, given your summary. So the question is, in the future, what is our expectations? So we are expecting that, if we have the whole room with plenty of stroke patients, in the best case scenario, is we are going to be cherry picking to get a 5% or 6% improvement as an absolute favorable outcome. It's like, are we like going grocery shopping? We get the bag, plenty of food, but at the end of the day, the one that are going to be tasty is only 5 or 6%? Thank you.
Thanks, Gus. I had written down that question because I was thinking I might actually ask Tudor or Gotts that. But the point is, I think, we cannot get better than 100%. So we all agree we have a ceiling of 100%, right? But we are nowhere close to that. I think, let's take a ranking 0-2 for the treatments that we have a wide gap. Now, we do agree that, I think we can agree that with certain treatments that we now have, that the benefit is going to be small. But incrementally, these do have effects. What we got to remember is that these effects, even like a 2% or a 3% effect, at the population level, when you're thinking of hundreds of thousands of patients, does actually matter. So then the question is, does the economics support that treatment? Obviously, these treatments are not going to work if the economics do not support it and the funders do not back that up. But I do think as scientists, we do have that moral obligation to go after and look at these treatment modalities that have these small effect sizes. And if they, prove themselves to be, depending on what type of trials we can do, then I think, it does help the field. So the question in front of us is, can we do large trials or can we be innovative in the way we actually do these trials? And that is what I think our field is now focusing on. The right tool to actually show some of these incremental effects. And then I think, the markets would actually tell us whether these should be translated to practice. Thank you.
Hi.
Go ahead, please.
Question about MR mismatch. We can use it for wake-up strokes. My question is, if you've got a known onset time of more than 4.5 hours, we use perfusion scanning. Am I asking is, can we use MR mismatch instead?
So I'm happy to answer this. If you refer to MRI mismatch, this is a bit fuzzy. I mean, you have to distinguish between perfusion-diffusion mismatch, which is MRI mismatch, and this is actually what was used in EXTEND to guide thrombolysis in the extended time window, so beyond 4.5 up to 9 hours. You can use this MRI mismatch, but you cannot just by concept use DWI flare mismatch because this is meant to identify patients with an early infarct. So this would not work beyond 4.5 hours. So I would clearly distinguish between these types of penumbral mismatch and a DWI flare mismatch.
Thanks.
Okay, if there's no more questions, so we would like to close this section, and we would like to thank all the audience and speakers for giving us so wonderful lectures. So thank you.